Hi, this is Brian Kim. I want to share with you case number 264 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best way, but to get you to think critically of your technique so that you can refine your technique and provide the very best for your patient. And so this is a case that actually got cut off in recording up until lens disassembly. And so you're going to see disassembly of this lens. But as I remove the last pieces and switch to IA, I'm going to think something very bizarre. I felt like the capsular bag was ripped in half. And of course, I was completely puzzled and shocked and perplexed on why and how this could happen. But you're going to see shortly why that wasn't the case. So I'll go ahead and place the chopper under the rexus edge contra-incisionally. I have the phaco tip somewhat down, use some vacuum to grab and lift the lens up, and then fracturing it in half. Grabbing that quadrant on the left side, using some vacuum to lift it up, and then crushing it with mechanical fracturing forces to crush the lens into smaller pieces. Again, using some vacuum to lift that piece up, crushing it between the instruments, and then emulsifying the lens piece. So yeah, I mean, the CDE just got started, so I just started disassembling the lens. I must have already performed the double chop maneuver before that. I'm turning the second heminucleus in front of me, placing the chopper under the rexus edge contra-incisionally to phaco tip deep, fracturing the lens at its deepest point to be able to fracture the lens effectively, separating the lens pieces, sliding the chopper under the right piece there, that third quadrant, pulling it centered toward the phaco tip and fracturing the lens against the phaco tip like a chopping block. Using some vacuum to grab that fragment up, getting around it with the chopper, flanking the lens, crushing it between the instruments, and then emulsifying the lens piece. And this is the final quadrant, using some vacuum to grab it up, getting around it with the chopper, flanking the lens, crushing the lens in half, using some vacuum to grab that fragment up, getting under it with the chopper, crushing it between the instruments, and then emulsifying the lens pieces. Again, using successive crushing forces by flanking the lens with the instruments and then emulsifying it. This is the last piece, getting around it with the chopper. Again, the same maneuver, flanking the lens, crushing the lens, pulling the chopper towards the phaco tip and crushing the lens against the phaco tip, using some vacuum to position the lens piece on the tip, and then crushing it with the chopper from underneath. You can see as I do these maneuvers, the chopper is turned a little bit sideways. So those of you who are worried about getting close to the posterior capsule, there is no need to fear. I'm able to turn the chopper sideways. The key is I'm able to flank the lens. And because I have the lens piece in a position that's not too close to the posterior capsule, I can turn that chopper sideways and effectively crush the lens in half. Use some vacuum to remove the epinucleal material, using the chopper to shield the posterior capsule from coming up. I'm very careful with the vacuum here. I don't want to use ultrasonic energy. Just let the lens pieces come out. So I take the chopper out. There's some pieces at the incision there. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INE handpiece. I always start sub-incisionally, peeling from anterior to posterior. I'm sweeping side to side to loosen up the cortex from the bag. You can see that the cortical material is kind of collapsing and coming into the port. It's not wanting to peel off in a clean manner. I'm trying to reflex a little bit here. Get that stuff out. Start again. Going to go after the left side here, peeling from anterior to posterior. But right here, I'm like, oh my goodness, what just happened here? Do you see the lines, those stria lines right there? I thought, oh my goodness, I just ripped the posterior capsule and split it in half. So I'm like, I'm not quite sure if that's true or not. So let's just keep going here. I switched to a slow-mo setting. You see I have a slow-mo setting, which is lower IOP, lower infusion pressure, lower vacuum. So I like that slow-mo setting. But as I proceed, I don't think that the capsule is torn. You can see there's a lot of puckering of the posterior capsule. There's a lot of stria in the posterior capsule. So clearly this patient has zonulopathy. So there's clearly some zonulopathy. I'm using the cohesive viscoelastic to push the capsule out of the port because I'm convinced that the port was actually holding a large bit of posterior capsule, and this is when you might accidentally rip the posterior capsule. So I'm pushing cohesive viscoelastic, and I'm visco pushing the capsule out of the port, and I'm just very carefully using the viscoelastic to gently extricate the posterior capsule from the port. And now that I did that, I'm able to push the posterior capsule back and out, and I'm going after that subincisional cortical material that's there, simultaneously pushing the cohesive viscoelastic to push the posterior capsule back. So again, I'm pretty confident that I don't have a posterior capsule rupture because when I pushed the cohesive viscoelastic, those striae lines went away. But you can see there's quite a bit of laxity to the zonules. And so I don't really trust the situation. I push some more viscoelastic to push the posterior capsule back, and then I come out with the INA. And then I'm doing a dry aspiration technique. This is just the 27 gauge BSS cannula. And you can see here, I'm just aspirating the cortical material from the subincisional area. I push viscoelastic out, and then I'm just going around very carefully doing a dry aspiration technique. Dry aspiration technique in this situation, I think, is really advantageous and just gets you a better idea of what's going on without high vacuum, high aspiration. It's a very controlled technique. Once I do that, I push some more cohesive viscoelastic to push the capsule wide open, and then I put the capsular tension ring in. So this is a capsular tension ring, and I'm just positioning it so that it's up and above so I can get to it in a better angle. I like to have the hook on the CTR injector pointed down. I'm grabbing the eyelet on the left side so that when it goes in, it rotates and goes in a counterclockwise configuration. But then when I inject the CTR, it's going to go out in a clockwise configuration. Lift the incision. Go in with the CTR injector. Go in with the Lester. Hook the leading eyelet with the Lester as I deliver the CTR. This minimizes the opening of the CTR, which minimizes torsional stress on the zonules, and then I'm able to deposit the trailing eyelet. This is a single piece acrylic lens. It goes into the capsular bag. Again, that technique of using the Lester hook to hook the leading eyelet is just very effective, very safe. It minimizes any stress on the zonules. And by keeping the CTR constricted, it minimizes the diameter of the CTR and therefore minimizes zonular stress on the CTR. Very effective, very consistent technique. And that's the way I always inject my CTRs. We're going underneath the lens, removing all the viscoelastic. Again, this patient has clearly some zonulopathy. I decided to put a CTR in with a single piece acrylic lens. Down the road, if the patient has a late IOL bag dislocation, I can suture and lasso the CTR and scleral fixate it. Again, just one way to deal with this situation. You can see I'm polishing under the rexus edge. The bag is nice and clean. The lens is nice and stable. You can see there's no abnormal wobbling or jiggling of the lens, and that is because the CTR is providing some equatorial support of the capsular bag. I remove the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. Again, as I was disassembling the lens and I was doing IA subsequently, you saw those striae lines in the capsule. I literally thought that there was a huge gap. Literally, that was a posterior capsule defect, and I was really surprised by that. Of course, I didn't panic. I stopped. I did some reflux the material that was inside the INA port, because remember, it is certainly possible in certain situations if you have extreme capsular bag laxity that the capsular bag, you can actually eat it up inside the INA port. And so I did reflux, I re-engaged, and then at some point you saw I pushed the cohesive viscoelastic to extricate the INA port of any material that was in there. Now, it could have just been cortical material that was within the port, but I used a cohesive viscoelastic to push the bag back and also to clear the INA port. If there was capsular bag material in there, that's really very important because you want to be able to get all of that stuff out If you accidentally start aspirating what you think is cortex, you might be aspirating the bag, and then now you're in trouble and you have to now do a scleral fixated lens. Fortunately, I was able to push the bag back, place a capsular tension ring with a minimal torsional stress technique, and this patient did very well. So I hope this was helpful to you, and I thank you for your attention.